am Dr. Eliot Brinton. I am an endocrinologist and a lipidologist, and I work at the Utah Lipid Center in Salt Lake City, Utah, USA. It is my pleasure and privilege to give to you a brief update of the AACE annual meeting, which was held last week. And so I'm going to start with some very interesting data regarding South Asians that was presented at the meeting. There was a talk about South Asian CVD risk factors, and you see them here on your slide. You can see that we have waist circumference. These cutoffs are lower than are used elsewhere because South Asians are very sensitive to just a little bit of central fat. Most of that adiposity at the waist is intraperitoneal or visceral, and that means there's an increased risk of cardiovascular disease. Also, you will note the BMI cutoff less than 23 for men and women. That is a lower cutoff for South Asians because there's more metabolic trouble, more metabolic syndrome at a lower body mass index. The blood pressure cutoff is the same. The total cholesterol, if we want to see it less than 160 in high-risk South Asians. For LDL, we would like to see it less than 100 in high-risk South Asians and less than 70 for people either with diabetes or with a prior coronary or other atherosclerotic event. And remember that the non-HDL cholesterol down here is always 30 points higher. If someone is a very, very high risk, that is that they've had more than one event, the LDL goal for would be less than 50, and the non-HDL goal would be 30 points higher or less than 80. For triglycerides, we'd like to see the triglycerides less than 150. We'll talk about those a little bit later. HDL should be greater than 40 in men, greater than 50 in women. A1C, we prefer to see it less than 6.5. And LP(a), we like to see it less than 20 milligram per deciliter. The upper limit of normal is 29, but it is a very common problem, as we'll discuss later, in South Asians, so we like to see that very low. So key takeaways, South Asians tend to have very high LP(a) levels on average. That's much of the reason for the increased risk that you know is prevalent throughout the South Asian area. And most of the calculators that we have for ASCVD risk underestimate the risk in South Asians. Please keep that in mind. There are reasons for this, as you see in the lower left. South Asians tend to have smaller coronary artery diameter. They may have other factors that cause them to have smaller intraluminal dimensions. We've mentioned already that South Asians have the excess metabolic syndrome and related traits. So higher triglyceride, lower HDL, increased ApoB to ApoA1 ratio. They have smaller LDL particles, which makes them more atherogenic. Smaller HDL makes them less anti-atherogenic, and they have an increased concentration of LDL particles, and also they tend to have a pro-inflammatory state. Finally, South Asians, as you know, tend to have a low intake of fruits and vegetables, high intake of saturated fat, often lack regular exercise, and then the genetic predisposition that we've discussed. Another talk was given about South Asians, actually several talks. To summarize briefly, South Asians are more likely to have multivessel disease requiring a coronary artery bypass graft, and some studies evaluating CABG show consistently poor outcomes for South Asians. So this is a very difficult thing. We've mentioned already the higher prevalence of insulin resistance, metabolic syndrome, etc. Also, chronic kidney disease and hypertension are rather common. Lipoprotein(a), very common. The health behaviors, the dietary habits, these are all very important. So the takeaway, LP(a) is often elevated. It's a very important risk factor. Please measure lipoprotein(a) in all of your high-risk patients. Anyone with a prior event, anyone with diabetes, anyone with a positive family history, measure that LP(a) and see if it's elevated. If it is, then we need to treat more aggressively with statins. Consider adding niacin, but then we have to watch to prevent diabetes with lifestyle and possibly pioglitazone. If you have access to them, the PCSK9 inhibitors are actually very good also for lowering LP(a) and for reducing risk. So we have several treatments. One that is not listed on this slide is lipoprotein apheresis. I'm not aware that that's available anywhere in India. I have actually a patient who comes to me from India for lipoprotein apheresis. So it can be done, but of course that's a very long trip, and maybe someday soon we'll have apheresis available in India. Perhaps someone's doing it there already. There's a QRIS3 calculator. There's a coronary artery calcium by chest CT. And of course, we have the lifestyle and other things that we need to do early rather than later. Let's shift gears away from South Asians, generally about diabetes, lots of presentations. This one lists 6 major treatments of diabetes, 6 major medication classes. Let's go through these very quickly. Metformin is usually first line. We don't have as good evidence as we'd like to, but we think it does help prevent atherosclerotic cardiovascular disease, or ASCVD. Sulfonylureas, of course, we've had around the longest, but they may cause hypoglycemia that will increase risk. They may harm the brain. They may accelerate beta cell burnout and insulin dependency. They're inexpensive, but really should probably be used as little as possible. I would like to discourage us from using sulfonylureas, really. Pioglitazone, on the other hand, is a very good medication, often second line after metformin. There's good evidence that prevents ASCVD, lowers triglycerides, reduces intraperitoneal and hepatic fat. We talked about that earlier, very common in South Asians. So this can be a very good drug for South Asians. Increases insulin sensitivity, increases beta cell survival. It may, on the downside, cause edema and must be avoided in patients with symptomatic congestive heart failure. Please do not use rosiglitazone. The DPP-4 inhibitors are interesting. They're good for glycemic control, but they tend to be expensive, and they don't really provide any other special benefits. So we really kind of discourage their use, and saxagliptin may actually cause or exacerbate congestive heart failure. Now, the SGLT2 inhibitors and the GLP-1 receptor agonists are very special. They're new, they're more expensive, but they are widely recommended for prevention of atherosclerotic cardiovascular disease. The SGLT2 inhibitors have a diuretic effect, so they're excellent to treat CHF, and they can even be used in patients that do not have diabetes for treatment of CHF. They also are very good at preserving renal function. They lower blood pressure, they help with weight loss, and they can be used, if the patient can afford it, in combination with the GLP-1 receptor agonists. The GLP-1 receptor agonists are also highly recommended for ASCVD prevention. They're very good for weight loss. They may help preserve renal function, and they can be used with the SGLT2 inhibitors. So key takeaways, we've got a growing list of diabetes medications that will help with ASCVD risk. Starting with pioglitazone and metformin, we can now add the SGLT2 inhibitors and the GLP-1 receptor agonists. Remember that optimal glycemic control is not just to lower A1C, but also to reduce the frequency of hypoglycemia. We really should never have that occur if possible. And there's evidence that variability in glucose levels is also an adverse risk factor for atherosclerosis and other complications of diabetes. Patients with diabetes are all at very high risk for fatty liver. This is especially common among South Asians, even who don't have diabetes yet. Pioglitazone is excellent for fatty liver, which is one reason why I use it so much, and I suggest that you do. We should follow for the development of chronic kidney disease. As you see over here, albuminuria and both decreased eGFR are important parameters, and it should be treated early to prevent progression. We can use the renin-angiotensin system blockers like the ACEs and the ARBs, in addition to the SGLT2 inhibitors and possibly GLP-1 receptor agonists. And we need to look at all the risk factors of ASCVD, including all the ones that I've mentioned already, including central obesity and Lp(a). So what about collaboration with non-endocrinologists using SGLT2 inhibitors for non-diabetes indications? Well, the SGLT2 inhibitors work for congestive heart failure and even renal insufficiency in people who do not have diabetes. So we have a team, you see this on the left, and the idea with this slide is to show us that we can work together as a team with general doctors, working with endocrinologists, and working with other team members to help use SGLT2 inhibitors, even in patients who do not have diabetes yet. So we have here a reminder on the left, the SGLT2 inhibitors are part of the management for CHF and CKD and diabetes, and even in patients who don't have diabetes, they can be useful there. Collaboration with endocrinologists with non-endocrinologists include collaboration, communication, understanding the indications, and there are innovation options for comprehensive cardiometabolic care. Now let's talk briefly about use of anti-obesity medications, or AOMs, after bariatric surgery. So bariatric surgery is wonderful, but there's a problem with weight regain after bariatric surgery. So what do we have? We have lots of medications approved by the FDA. We have orlistat. That's kind of an old school drug, but it's a good one. It blocks fat absorption, as you know. We have phentermine, which can be used in monotherapy, rather affordable, and it blocks appetite. There is a combination of phentermine topiramate, which is available at extended release as a branded product. It is expensive, but you can do it inexpensively by simply giving phentermine and topiramate as separate pills. There's another fixed-dose combination, bupropion, naltrexone, rather expensive. Liraglutide, a shot, semaglutide, even more effective, but it's also a shot and also rather expensive. And then tirzepatide was just approved actually less than a week ago. And the second day of the AACE meeting, it was approved by the FDA. It is also very expensive, but it's very effective. It is a combined GLP-1 and GIP agonist, and it's very, very effective, very exciting, but very new and rather expensive. There's another medication over here in development, but the idea is that we're suggesting use of anti-obesity medications as may be needed for weight regain after bariatric surgery. So the key takeaways are to initiate them after weight. You can have to do it after weight regain. You can also do it when they get their nadir weight or their weight plateau after the surgery. Treating even with 2 or more anti-obesity medications may be helpful. And of course, patients need support for optimizing exercise, diet, etc. Okay, another brief one here on hypoparathyroidism. We're going to measure the total serum calcium, ionized if they're normal calcemic. Hypoparathyroidism is a consideration. Phosphorus and TEC-PTH, 25-hydroxyvitamin D, and creatinine for looking at kidney function. Skeletal analysis by DEXA, renal in more detail as may be needed. Genetic evaluation is possible, although not necessary. Alendronate or bisphosphonate, we've had around for a long time, is very helpful. The newer drug denosumab can also be used to increase bone density that may have been lost earlier on. Cinacalcet can be used to reduce serum calcium. Calcium intake and supplementation with vitamin D can be helpful. Postmenopausal estrogen therapy can be very useful, but you must start before age 60, otherwise you cause quite a bit of harm. And then parathyroidectomy is very, very helpful, but must be done by an experienced surgeon. So parathyroidectomy is attractive. You may need to refer your cases to an endocrinologist and certainly to the right endocrine surgeon. Cinacalcet, as I mentioned, monitoring the serum calcium, creatinine clearance, the DEXA every couple of years or so, and then bisphosphonates, denosumab, and estrogen will help preserve the skeleton. Okay, last topic, and let's go into this a little more detail. This is part of my area of focus. Since I'm a lipidologist, I'm going to go a little further. And I also think it's very, very important for those of you who are practicing in India and possibly other parts of South Asia. So the risk of atherosclerosis shown here on the vertical axis is very steeply associated with triglycerides. And notice the range. This is 100, this is less than 100, this is 200. Notice how steeply the risk of ASCVD goes up, even over very low triglyceride levels. Probably the vast majority of your patients have triglycerides over 100, as is true also in the US. And notice that even at 100, the risk is already higher, and it goes up very steeply up to 200 or so. So please remember that just a little bit of triglyceride elevation can greatly increase the risk of ASCVD. Now, those are patients that are not taking statins. What about patients that do take a statin? Here are data from one of several studies that show the same thing. Even though these patients are on aggressive statin therapy, they have an LDL less than 70, so they're at goal. Notice how much higher their risk of ASCVD is simply going from a triglyceride less than 150 to greater than 150. So even if we have a patient on a statin and their LDL is at goal, if their triglycerides are elevated even just a little bit, the risk is much higher. And the next few slides will show us what we need to do to block that risk. Well, let's go to 2 trials. You probably heard of Reduce-IT. This was first published several years ago. Much more recently, last year, was the STRENGTH trial. As you can see, these trials are very, very similar. Look at all these rows in the middle, very similar, except Reduce-IT used EPA, a pure EPA product called icosapent ethyl, 96% EPA, as pure as it can be. STRENGTH used a mix of EPA plus DHA. So does that make a difference? Well, the quick answer is yes. There was no benefit in strength. The hazard ratio was basically 1, whereas the hazard ratio in reduce it was 0.75, meaning there was a 25% reduction in risk in reduce it. Why is that? Is that because there wasn't enough EPA or maybe too much DHA? Well, let's look at it. Here you see data from reduce it. See that blue curve? Notice how the higher the EPA levels in the plasma, the greater the benefit for the primary endpoint, the secondary endpoint, cardiovascular death, total mortality. There's a very steep slope. The higher the EPA levels, the better the result. And notice that strength did not have as high an average EPA level. So the question is, was it not enough EPA? And the answer is no. Because if you look at the strength patients who had the highest EPA levels, they still did not have benefit. So if you're in the strength trial and your EPA is down here, where you clearly saw benefit for reduce it, there was no benefit in strength. So that implies that this is because of an increase in DHA, and DHA levels went up rather dramatically in the strength trial, whereas they did not go up and reduce it because we didn't give them DHA, whereas strength, they gave the patients DHA and the DHA levels went up. So could DHA be that harmful? The quick answer is yes. Here's a membrane, a cell membrane with EPA, and here it is with DHA. The DHA membrane has a different desensibility. Notice these little yellow things here. This is cholesterol over here. The cholesterol is in red. Notice how the cholesterol clumps together in the presence of DHA, whereas with the presence of EPA in the membrane, the cholesterol stays spread out. So is that a problem? Well, it's a problem because, first of all, there tend to be pro-oxidative factors down here. And as you get oxidation, which can pass easily through the cell membrane in the presence of DHA, then you drive the cholesterol aggregation. Well, so what? The cholesterol aggregation causes the formation of a large cholesterol crystalline domain. Those cholesterol crystalline domains, what do? They become cholesterol crystals. This is an electron micrograph of a huge cholesterol crystal with some macrophages. Notice how big that crystal is. It's big enough that it kills the macrophages, and it can also cause plaque rupture. So adding DHA is a bad idea. Adding EPA is a good idea. Here's our old paradigm, the statin adjunct pathways. We have optimized statin therapy. We're going to the right. We're going to add ezetimibe. We're going to add a PCSK9 inhibitor. These are all proven to reduce events. So if we need more LDL lowering, we go to as high dose of statin as the patient will tolerate. Then we go to add ezetimibe or a PCSK9. This is all good. But we now have a new paradigm. And that new paradigm is when we're here trying to treat LDL, we have to look at triglyceride levels. And if they're above 150, despite our best effort on the LDL in this direction, and this is going to be very common in South Asians, if it's above 150, then we have to go in this direction to try to add icosapent ethyl. The brand name for that is Vascepa. You're able to get it in India, but it's not sold in pharmacies there, I don't think. So it's a little tricky. You're probably going to have to go to an online ordering system. There's several pharmacies that might do it for you. If you can get Blink Pharmacy to help you, Blink does a very nice job with Vascepa in the US, but I don't know if you can use Blink to get it in India. So you may have to go with some other source. Unfortunately, icosapent ethyl is rather expensive, even in the US, and you're probably paying more in India, but see if you can get it. So it is indicated for prevention. More than 20 medical associations have recommended what I just told you about icosapent ethyl in these patients, treated with statin first always, but with a prior event or diabetes or both. And of course, you have a lot of those patients. And then just in passing, a brand new study, Prominent, has suggested neutral results, which says that maybe fenofibrate, which we've used a lot for ASCVD prevention, may not work. So fenofibrate is, as I'll show you here, fenofibrate is first line for severe hypertriglyceridemia, but probably not useful for prevention if the triglycerides are under 500. We have all these risk factors. We want to get that non-HDL under 100 or even under 70, depending on the case. We have all the things tied up with high triglycerides. We want to add icosapent ethyl to statins to prevent ASCVD in the patients whose triglycerides are over 150. And then, of course, we're going to treat diet, lifestyle, secondary factors as best we can. Thank you very much. I really appreciate your listening.